is founder of the ACL Hub, and I've got the absolute pleasure of talking shop with Stephanie Allen for the next 45 minutes or so. So those that don't know Steph, she's a force on Instagram, social media. She's a wonderful physical therapist from the US. Has also unfortunately injured her ACL in her younger years, and has certainly got some skin in the game, as well as being a great clinician and a leader in the ACL force. She's got personal experience as well to sort of help her patient load, and really share great messages, which I value and appreciate, what she does online too. So Steph, welcome to the ACL Hub, and thanks for having a chat.
Very pumped to be here, Mick. Thank you. You were actually, I think when I first started to dive deeper into
Mm.
ACL specific stuff early in my career, you were one of the first voices of reason for me. So it's
Oh,
honor to be here.
feelings mutual. It's an interesting one, because I don't know, I felt like a bit of a fraud early on when I was sharing blogs and writing blogs about ACLs, and I don't know, I just sort of certainly growing more comfortable over time. I still don't, consider myself to be a leader in the field. There's much cleverer, smarter people out in the world who are doing great research. I just like to sort of distill what they do, and try to put my own personal experience and clinical experience on it too. So, no, it's nice to be able to do that, and no doubt you sort of do it. You're feeling the same way in yourself. It's yeah, it's a cool place to be.
Yes, plenty left
Yeah.
to learn.
Yeah, exactly right. Well, I won't butcher a bio. I won't. I tend to do that, so I might, for those that maybe, or those that are reading and listening to this blog and this interview, I might get you to give a little intro about you and what you do before we dive in, if that's okay.
Yeah, definitely. It's been a, windy career, I think, as a lot of people's are at this point. I'm currently fully virtual.
Yep.
I started a virtual ACL coaching business called ACL Resolve in 2021. Kind of weird that it's been this long
Mm,
already, but also co-founder of Clinical Athletes. So I work on that end as well, a little bit more on the education side. So I get to scratch both itches in terms
yeah.
of being a mentor and also continuing to kind of be in the trenches and actually working with people who have had mostly an ACL injury, but generally knee injuries. We have a little bit of a
Yep.
variety, which is nice too. Prior to that, I was in a general outpatient clinic for, oh gosh, um, 8 or 9 years,
Yep.
and kind of doing the thing there. I think the last probably 5 or so years that I was actually physically in clinic, maybe a little bit more than that. My caseload outside of clinic learning by choice and everything was pretty much all ACL.
Yep.
I'm sure we'll get into it at some point, but it continues to, in some ways, baffle me, but like fascinate me and interest
Yep.
me. And also, there's some areas too that I feel like I have a pretty good handle on at this point that,
Yeah.
feels good with being able to help people in those areas too. So, yeah, it wasn't necessarily a choice to start my business. It was a
Mm,
little bit of necessity because when the majority of your caseload, at least the way things are run in insurance-based clinics in the US, the majority of your caseload is ACL cases. It's tough in terms of, I was pretty much programming for everybody outside of their sessions,
yep.
writing progress notes for insurance every couple weeks,
Yep.
getting denied, doing
Yeah.
appeals, things like that. So it was my choice to build up that part of my caseload, but then I got there and I was kind of like, oof, there's there's got
Yes.
to be a bit of a better way. So it just was a little bit of a diversion path that I carved.
Yeah, it's interesting, and it's fascinating hearing different healthcare systems and how things sort of operate from country to country. Look, I'm sure every physical therapist, physiotherapist around the world has got red tape and many hours spent doing admin, and probably not forward, patient facing as much as they'd like. But I think the message I'm hearing there is, like you certainly develop this expertise by seeing a high volume of ACLs, and each ACL is very different. Like I often get asked the question, don't you get sick of talking about ACLs, treating ACLs, and seeing ACLs most days per week? And it's like, no, because every ACL belongs to a really interesting human being. Not only the human being, but also to the surgical side of things is very different from person to person, and where they're at in their journey is going to be different. So, not everyone's going to be, 3 months post-op, and it's not rinse and repeat. Like, you're going to have a really diverse range in your clinical day. There's going to be acutely injured all the way through to late stage ACL rehabbers. You got non-operative management, so on and so forth. So for such a tiny piece of the human body, it's such a fascinating and diverse group of people that we'll get to work with. So that's pretty cool, huh?
Totally. Yeah.
Yeah. So tell us a little bit more about, like, beyond being a great clinician and developing this great online presence, what was kind of like your background? I'd sort of alluded to the fact that you injured your ACL as a high school. Can you take us back, if you're happy to talk about your injury experience, and kind of then no doubt has sort of led you walking down the path of trying to help people who've been through similar situations?
Yeah, it was interesting. I think for me there was some some bigger context around it as well. So
Mm,
it was my senior year in high school. At that point I was playing basketball pretty much all year round. I did play multiple sports. That was one, especially like research people are like, did you play one sport? Because that's a
yeah.
high
Yep.
risk for injury.
Mm,
No, I did play at least two sports at that point. And interestingly enough, I was very convinced at that point that I was going to go to school, like go pre-med. I wanted to be, it
yep.
changed many different times, but I eventually wanted to be like several different types of surgeon.
Yep.
So I was not even at that point, like junior, senior year in high school, when
Mm,
most kids are kind of deciding if they're going to decide.
yep.
I was not actually. I had applied to two physio schools, just as almost kind of like oh well, we'll see if I get into one type of thing.
Yep.
But after I got injured, it changed my perspective a little bit. So I'll
Yep.
get to that. But the injury itself, I think, um, it's worth talking about. At the time, I was also, it was right before, but I was like pre getting formally treated for an eating disorder. So from there's a whole other subject that sometimes comes along
Mm,
with ACL injuries in females in terms of low energy availability, red S, some of the
yep.
nomenclature is changing now. And I don't think that's necessarily the whole picture, but I
Yep.
think it was a big piece of the puzzle for
Yep.
me. Because I can remember feeling that year that, I would go to do stuff on the court that I normally wouldn't have to think twice about doing, and my body just
Yeah.
like wouldn't do it.
Yeah. Yep.
Um,
Yep.
you don't think about that kind of stuff at that age too. I was 17.
Yep.
So, that was all kind of part of other stuff happening at the same time. The injury just, unfortunately for me, was kind of like the cherry on top in terms of like
Yeah.
everything else that was
Yeah. And was that a
going on.
self-imposed sort of pressure and motivation? Like at that time when that, you're kind of reflecting on low energy availability, where you just like training the house down and kind of just, like pushing yourself physically, hours and hours and going hard at it.
Yeah, oh, sorry, go ahead.
Yeah, no, that's okay. And or like, did obviously schooling and that time of
High
life, like
pressure.
it's such a high pressure situation, which no doubt a
Yep.
lot of young females and males sort of go through, but particularly a high risk female group. Yeah, was that like a story for you?
Yep, I was the typical high achiever.
Yeah,
I
type A
don't think,
personality.
yeah, I don't think I got below like an A minus my junior or senior year.
Yeah,
I think I got a B plus in like driver's ed or something, and I was so mad.
yeah,
But yes, it was largely self-imposed pressure. There was some familial stuff going on.
yeah,
And our town, I'm from a very small town, and I started varsity basketball as a freshman.
yeah,
And again, like that sounds kind of crazy, especially, but we were, it was a small town, but it was still a big thing. It was like a
Yeah.
meaningful thing. And we hadn't been great for a lot of years. And so
Yeah. Yeah.
my class in particular and the class below me, we were kind of like the best chance to like win a state championship.
Yeah. Yeah.
And we got pretty close my junior year. And the night that it happened for me, it was like a week or two before the state tournament. And we were like
Yeah.
pretty highly seated. And so it was a real like, it was a, again, at that point, to me right now, obviously, like that's not the biggest deal in the world. But when you're
Yeah.
17 and you're
Yes.
there, I was probably not going to play in college. Might have
Yeah.
played club. I was going to focus on school.
Yeah.
And it was just like, it was a big, it was a big thing. And that kind of, to circle back, you know, the kind of stickler I am for like talking about the mental side of things.
Yeah. Yeah.
I really do feel like it came from that, and with the fact that like during my entire, it was a very short rehab process.
Yeah.
Unfortunately, it wasn't great, but nobody ever talked to me about it, asked me, like I was so scared, like
Yeah.
so scared to, and I never did. I played like a couple of club intramural games.
Yes.
Uh, but I basically just, you know, still for a while after pretty much just ran over exercised, underfueled until like, you know,
Yes.
and then, you know, middle to end of college really kind of got straight there, but
Yeah. Okay. Yeah.
lots of factors.
Yeah, so that's yeah, like that's a lot to unpack there, but I think there's a lot of things. I guess first and foremost, like we often sort of blame, and this is definitely the thing that's starting to gain traction, and it's certainly within ACL circles. We're getting a better, probably, yeah, a better communication around this. But the blaming the female anatomy on injuries is, it's starting to be a conversation of the past. It still lingers around, no doubt, a bit in some circles, but probably those that are involved in the field heavily will start to appreciate and start to sort of talk about the wider appreciation. And what you're saying there is probably that pretty typical story where there's a lot more going on than
Yeah.
female anatomy, wider pelvis, and all these anatomical and
Hmm.
hormonal influences that are causing injury. There's going to be a whole lot of stress and mismatches in work-life balance and load
Totally.
perspectives. But we haven't even sort of talked about the opportunities that you're available to get at that time, being a young female. What the men get, what the boys get, versus what the girls get, and the opportunities. And that in itself is a huge thing, which we could probably spend another hour talking about. But I
Hmm.
think, yeah, that's a big thing. And like for those that work here in Australia or different countries around the world, what kind of did your rehab look like? Because my understanding of the American system is pretty much that you get allocated some insurance time to rehab. Some mostly of people are saying it's 6 months. I'm not sure if that's changed, but it seems like you sort of get 6 months of access to a physical therapist and you get sort of kicked out the door. Is that kind of a thing, or is that just sort of hearsay?
Yeah, it's not crazy dissimilar still. I think the differences now are that because there are definitely more PTs, more physios who are
Mm.
wanting to maybe more specialize or work more in, you know, higher performance sport or with people that are, because most people that tear their ACL are pretty active. They're not usually
Mm.
sedentary people unless it's kind of like a traumatic incident somehow. Um, so they're catching on that like, okay, probably 4 to 6 months, which was like definitely what even the PTs were saying when
Yeah.
I was getting rehab. It was 2007. So
Yeah.
um, that was just expected. Like 6 months was like, you know, already seemed too long anyway, and most people were going
Yeah.
back around that time. There was no real strength testing, anything like that. So, yes, the short answer is yes, mostly based on insurance. So,
Yeah.
insurance will either here will give people a certain number of visits per diagnosis per year,
Yeah. Yeah.
or they will give you it has to be used in a certain time frame
Yeah.
because with private insurance it's so different.
Yeah.
There it's very variable. But that being said, whatever the contingency is with each plan that somebody
Mm.
has, it isn't usually going to cover probably more that you'd be lucky if you got, I think, 6 months worth, especially if you're going
Yeah.
2 or 3 times a week, which is,
Yeah.
tough. And then what's happening a lot now is that these insurance-based clinics will just have a cash pay rate that people will kind of like switch over to
Okay.
after.
Yeah.
But again, that also kind of, makes shrinks the pond a little bit because not everybody's going to be able to do that.
Yeah, for sure. And so what was your experience in that rehab period of time when you were, 17? Like, would you rate your rehab over 6 to 12 months, good, average, poor, self-reflecting on
Yeah.
your attitude and your rehab?
I now knowing what I know, it was pretty poor.
Yeah.
I think it was probably average for then. I didn't have anything to compare to. Nobody in my family
Mm.
had a serious injury at that time in particular. I'm not super duper old. I'm 36, but it was basically half my life ago.
Yeah.
And when you heard ACL injury, even in professional sports, it was usually a career ender. It was
Yeah.
still kind of like, at least, I know my dad, my family, like that was the belief. So I don't even really think that I gave myself the chance to believe that I could
Yeah.
could get back. Now it's so different, but
Yeah.
yeah, it was. Will never forget it because I really did. I liked my PT, and that's one of
Yeah.
the kind of like gripes that I still have now is most PTs are really nice, but not all of
Yeah.
them are capable of
Yes.
working with an ACLer.
Yeah.
So that was me, and he was super nice. It was this small clinic on top of a bank in the
Yep.
center of town, very small.
Yep.
I think I was the only person under 60 there.
Yep. Yep.
A lot of ice stim, Bosu ball stuff. I think I was running at like week 9 or 10, mostly because I just wanted to and I didn't have any
Yep.
more
Yep.
pain, but there was no strength test or anything. And I was
Yeah.
definitely, I was not strong.
Yeah.
Uh, and so it was, and the other constraint that I particularly had was this happened when I was a senior. I was going to college in August.
Yeah.
So I got the surgery, I think in April or March, maybe. I could be wrong, but I think I ended up having like 3.5 or 4 months of PT, and then I went to school and I just didn't.
Yeah.
eh, I was
Didn't
like,
go
I'm
beyond.
running. It doesn't hurt. So I didn't have full extension, but
Yep.
I was,
Yep.
I was running and it didn't hurt. And college stressors were now in place. So
Yeah. And I think that's probably a common story that, I mean, certainly if we go back 15, 20 years ago, we probably wouldn't, hear, we would certainly hear stories that are very, very similar to that, particularly with teenage kids, even kids at college. You'd kind of get to a point where, but yeah, 20 years ago, we didn't probably know what we know now in terms of, criteria driven rehab and making sure that we're hitting criteria and numbers before we sort of move from one phase to the next, which is very commonplace now. But I also still think there's a large body of our population that will get to that somewhere between 3 to 6 months and not have much pain and think they're good, and will kind of just sort of fumble their way through the last 6 months. And credit to them, they'll generally stick to the don't play before 9 to 12 months, but they'll kind of, you may lose them and you may not keep checking up on them, but then lo and behold, they're three things will happen. They'll be fine. Not many of them, but the other third will probably won't go back to play because they don't have the confidence. Probably similar to you. It sounds because do you think upon reflection, like the fact that you didn't go back to that higher level sport, was it confidence driven, or was it just you had other things going on in your life that you just didn't go back?
no, it was definitely confidence and fear because if I
Mm.
could, interestingly enough, there were two girls that I played AAU basketball with like off season
Mm.
that played at the school that I went to. And they
Mm.
were like, yeah, I mean, it was Division 3. It wasn't like, it's still a high level, but
Yeah.
um, especially looking back, I could have played if I
Yeah.
was, if my rehab
Yeah.
track was different. I think if I tried to play with the poor prep that I had
Yeah.
had, both mentally and physically, I probably would have been at really high risk for another
Yeah.
injury.
For sure.
Um, So in that sense, I'm glad. But yeah, it was definitely confidence and fear driven.
Yeah. And fast forward, to now, I remember like you recently had to have further surgery on your knee, is that right? Is
Yeah,
that
in
is that a hang
2022, I had a stroke.
yeah, is that a hangover from the injury, or did you acquire it over, through an acute injury over time, or yeah, if
No,
you're happy to.
no, no real MOI. I think for me, my guess, because the surgery itself was anterior interval release, which was basically just a pocket of scar tissue in the
Yeah.
front lateral part of the joint, which was
Yeah.
um, starting to get painful and also starting to limit extension even a little bit more.
Yeah.
And then I also had a little bit of a pesky, I knew it was meniscus because
Yeah.
they didn't repair mine. They just partially removed it
Yeah.
at
Okay. Yeah.
17. So more of that had to come out. And then they did some like basically chondroplasty, which is just kind of like shaving some of the surfaces that have become jagged with arthritis, just to
Yeah.
shave them
Yeah.
down.
Yeah. Yeah.
I contemplated doing it versus not, but I think that it was interfering enough with running,
Yeah.
because I wasn't really playing a sport at that point and just uncomfortable during most days. And I was like, I know eventually I'm probably going to need a
Mm,
partial or full knee replacement, but like not yet.
not yet.
Um, but yeah, I do think that was related to um just not having great rehab slash
Yeah.
again, I don't know how much of the other sort of continued, I continued on another several years with like low energy availability after that. So I
Yeah.
don't know how the healing environment with the cartilage and bone underneath,
Yeah.
maybe it wasn't optimized for some of those reasons too.
Yeah.
Um, but the other knee is fine. So so
Yeah.
I
Yeah.
would have
Yeah.
to
Yeah.
imagine it's probably related to the surgery.
Yeah, and definitely, yeah, like we all know, those that work with ACLs, we're going to see 50% of the populations have some degree of change in their knee 10 years down the track. Some people
Yep.
unfortunately develop that change much earlier, in the first even 12 months. We're seeing some
Yep.
changes in some people, but yeah, a big chunk of people up to about 10 years down the track, we're seeing some change. So it probably fits with the timeline for you. Did you ever get full knee extension? You sort of mentioned that earlier, that you didn't achieve full passive or active knee extension early,
Nope.
and that lingered through the next 20 years.
Yeah, because it was
Wow.
something I know it's crazy, right? Because like I didn't, and again, timeline, I didn't really understand the importance of the basics that,
Mm,
I try to live by now with
yep.
people, really until like probably close to between 10 and 12 years after my injury.
Yeah.
Um, so because like if some, and again, let's remember I'm the type A kid. So if
Mm,
my PT had told me you really need to get full extension just like the other leg,
yeah.
I
You
probably
you
would
you
have
would
had
do
it
it.
month one, you know. But it wasn't, it was, I
Yeah.
think back to like again, I'm not going to remember verbatim, but there was never any, one of the things I'm big on now is like there's lots of early conversation about expectations. And
Mm,
like that just didn't really happen. I went on the bike, I did
yep.
similar exercises, and then I finished up on ice and stim in slight
Yep.
flexion. So, it's like,
Yep.
so yeah, and that also, to be honest, probably had some impact on arthritis development too, because if you don't have normal joint mechanics,
Yep.
there's areas being loaded that weren't necessarily
Yeah.
before. So
Yeah, for sure, for sure. And so, I mean, that's, it's fascinating, like hearing that, patient experience, and now, and so probably taking your patient hat off and putting your physio hat on now. Like, it's,
yeah.
do you have a philosophy, knowing what you know and knowing what you've been through, like, and you've got an interesting caseload now. You've had the face-to-face, hands-on stuff, and now you've kind of moved remotely. If we got, without diving one way or the other, like, do you have necessarily a non-negotiable, or let's say philosophy, before non-negotiables? What's your, I guess, philosophy to rehab, especially in those first 4 to 6 weeks when we're dealing with someone either remotely or face to face? What are your kind of key messages that you try to instill in your patients?
Yeah, I'm very simple. in the
Mm.
beginning, because I do think that a lot of what is still sometimes being missed is the really simple stuff in the beginning.
Yeah.
Um, I'm a poster child for that. So I do have that conversation. Again, there's some caveats or slight differences, especially maybe with weight bearing or range of motion, depending on what types of surgery somebody has, like whether they have
Yeah.
meniscus involvement or, some bony injury. Sometimes people have a fracture with it too. So there's some different sort of precautions that they're allowed to or not allowed to engage in terms of like movement and exercise in those early weeks. But
Yeah.
for the kind of straightforward ACL, nothing else was reconstructed or repaired.
Mm.
Um, it's a clear conversation, and this is your job to accomplish these things in the first whatever 4 to 6 weeks. You got to get it calmed down. So you got to get swelling down so that, and I tell them why. The without it, the
Mm.
quad's not going to work on its own, and
Yep.
you're not going to get the range of motion that you need to. So that's your biggest priority, which will also include like sleeping enough, eating as you would eat like you're normally training,
Yep.
drink enough, all those things, things I in my early in my career I never had those conversations, but I do
Yep.
really that the early phases there's in although we want you to be doing stuff early and often, which we'll instruct
Yep.
you on, you got to allow the body to like do its thing a
Mm.
little bit,
Yep.
instead of trying to just bust through stuff, because if you try to push through the range of motion too
Mm.
early, be up and walking around just because your weight bearing is tolerated and you're trying to,
Yep.
get 5,000 plus steps a day, like the swelling's gonna linger.
Yep.
You're not gonna be able to really achieve those early milestones. So to make the short list, it's essentially like calm, quiet knee, get the swelling down as quickly as possible, achieve full extension, because even if you have
Yep.
a range of motion restriction, it's usually not limited in
Mm.
extension unless somebody has like
That's
a
it.
PCL injury or something. Um, get the quad firing. There's different ways that we can do that that don't require you to be weight bearing or to go through a certain range of motion. And then if you are able to weight bear, we talk about, not in those first few days, but maybe in the first couple of weeks, some kind of like gait or walking
Yep.
training, because I do think that, you know, if people are wearing the brace a lot, it messes with your walking pattern. And if you don't
Yep.
kind of practice that, it can linger too. So
Yeah.
they're
Yeah.
literally have like kind of 4 mini jobs.
Yeah,
That's it.
love that simplicity, and it certainly aligns with my approach too. I think the value in just getting the swelling down has just got this profound knock on effect to improving range, decreasing pain, naturally getting a bit more excitement in your quads. It just doesn't have fluid sitting around impeding its ability to contract, and those three things that are naturally just going to help the body move. So I always just try to sort of hone in on those and really double down on the swelling control, because if we look after that, it's going to help so many other things along the way.
Yep.
um how do you, I guess, interesting, like caseload now going online, like how do you navigate that now that you actually aren't sort of forward facing? Like do you find yourself having, like if a patient needs e-stim or, muscle stim, like to help with their muscle contractions, cryotherapy, all these kind of things to help complement their essentials. Obviously that kind of stuff, arguably it's generally important, but if it doesn't get done, it's probably also too not the end of the world, as long as they've got other strategies in play. How do you sort of navigate that? Because I see some telehealth patients still, but always interesting to hear how other people manage their remote patients in this kind of early setting.
Yeah. And I would say probably percentage wise, maybe 30 to 40% of our client caseload. That's a guess, but
Yep.
there's not a ton that are like immediately post-op.
Yeah.
But
Yep.
at this point, we've had it enough, and I kind of like it. I mean, it does require a little bit more checking in, maybe a little more
Mm,
FaceTime in the
mm.
beginning. To be honest, I was doing that anyway when I was in the clinic. I
Yeah.
was talking to people between sessions. And so it is a little different in that sense. But at this point, I've kind of built up essentially some resources
Yeah.
written video, things like that, where
Yeah.
we know when they're getting surgery, we know when it's happening. I let them know what things would be good for them to get if they can
Yeah.
in the house if they need it. There's an NMES machine that I found that and was sort of approved by a couple of my mentors in terms of being strong enough
Yeah.
for what
Yeah.
people can use early on that isn't like $300 or $400 like
Yeah.
the one we use here a bunch that's kind of clinic or medical grade is like
Yeah.
$100, which
Yeah.
people are already paying and investing to work
Yes.
with me.
Exactly
I'm not
right.
going to be like, okay, you also need to get all of these things. So there's a very short list of things that are affordable that I tell them are probably worth getting. Compression sleeve, um, ice machine with, or some sort of ice thing that goes around their whole leg, doesn't have to be crazy. And
Yeah.
the enemy is just for early on. And I have a full like written out, okay, this is what pads to get. This is where you put them.
Yeah.
These are all the settings. Just because I've done it enough times where I was like, okay, I need to actually just write this stuff out.
Yeah.
So the full sort of onboarding, if you will,
Yeah.
in the
Yeah.
sense. And then we like, if we need to add a short call or a Zoom call so I can,
Mm.
'cause sometimes people get it a little quicker than others,
Yeah.
and I want to make sure that they're doing it well, then we can, yeah, can spend 10 or 15 minutes and we can, go over it that way. So there hasn't been a lot of friction on that end. I would say more of it is there was just kind of over the first couple of years, a lot of work in creating some of these resources on the
Yeah.
back end.
Yeah, exactly. It's probably a little bit more effort at the start, but now it's probably now the resources are
Yep.
done. It makes it easier. It's unique injury. I think there'd probably be a couple of other injuries around the body where you could 100% manage it online or remotely if you had a patient, and they couldn't come into the clinic to see you. There's a couple of things a couple of other ones that I can think of, but ACLs in particular, like you got to largely you got a diagnosis already. You know what surgery they've had, you know what other procedures they've had, you know what the limitations would be in terms of range or weight bearing and all those kind of things. And some surgeons will have different protocols and whatnot, but 95% of cases you'll be able to sort of clinically reason your way through those first early stages if you see some of them, and it is largely education. There's
So much.
so much education early, setting the scene, setting the platform, and there's only so many exercises you can get away with in those first few months. Well, sorry, the first
Mhm.
month, because they're so load intolerant. So yeah, it is one of those injuries, because I've had people ask me, like, how can you look after an ACL patient if you don't have your hands on them? It's like, well, do you really need to have your hands on them all the time? You don't need to be
I wasn't doing it
necessarily,
in clinic,
yeah,
really. I
no,
showed them how to do patellar mobs because I was like, yeah, I can do this in the beginning for you, especially
yeah,
with like a patellar tendon graft. I still think
yeah,
that's a good thing to
yeah,
do. But you're gonna have to do this at
yeah,
home
at
like
home,
several
yep,
times a day. I'm not gonna help you doing it twice a week.
yeah, that's it.
But I do also like it doesn't always work this way, but there is often either, a PT that they know and trust that either I can speak with
Yeah,
briefly or whatever, and they can
yep,
kind of have a set of eyes and hands in person in those early weeks and
yes,
just go once a week or once every other week. I like
yep,
that.
yeah,
Um,
100%,
and I
yep.
think that works really well for them mentally too.
Yeah, great. And it's same situation. And I think they need it. Like if you have a patient that is checking in with you remotely and they you're looking after say 90% of their care, I'll always ask that person, have you got someone nearby you can reach out to, and go to see in the event that you have like a really big pain flare and you need to sort of calm things down with some compression or some hands-on therapy, or even
Yep.
just to have a physical face-to-face conversation, because sometimes you can't quite see sometimes through the video like how things are truly. So it
Yep.
is good to have someone. And then obviously for testing, like for strength testing and
Totally.
hop testing, jump testing, all those kind of things, like you need to have someone on the ground to be able to do that, to feed you the information back. So certainly
Yep.
that really strong collaborative approach is good, which kind of leads into the middle to late stages. From a for you, is that like exercise, obviously exercise prescription is such a big one there. How often are you sort of checking in? Someone's moved through to the running and running, jumping phase. Are you sort of seeing them like once a month, once every 6 weeks for checkups? How do you kind of navigate the remote situation when someone's kind of moved away from those early stages where it's just all about calming things down, and now you're trying to build it up and move forward? Yeah. How do you kind of set the scene for those people?
Yeah, ideally, if we can, I love to have some form of initial kind of baseline or threshold strength testing in the early, like in the sort of entrance to the mid phase, so that I can tweak their program appropriately.
Yeah.
That also being said, just quick caveat, like that first strength test, whether it's isometric or isokinetic, I'm usually telling them again, education, but like
Mm.
it's probably more of a threshold test for you. I'm not wanting you to kick through like a certain level of pain. This is really just kind of seeing where we're at and how it feels. Because hopefully they've been doing the extensions by then at that point.
Mm.
And
Yep.
um,
And but just before you go, you're an advocate for knee extensions. It's one of the questions I always ask physios who are coming on.
yes, yes, yes.
What's your feeling, thoughts and feelings there?
Yeah, I think the only thing that I won't do with them early on is probably just from a, you know, conservative risk mitigation standpoint. I'm probably not going to load super heavy near full extension. Like I'll have them
Yep.
kind of go 90 to 60 or 45.
Yep.
But there's pretty conclusive evidence that if the knee is bent past 30 degrees, the ACL is,
Mm.
there's not really a ton of tensile load through it. And I spoke with this, or think I spoke with Eric Maida about this, but I first heard him talk about how, like, at that stage, they can't really lift heavy enough with a
Mm.
single leg knee extension to for there to be like enough newtons
Yes.
of like if you watch an ACL surgery, especially like bone patellar bone, that graft is in there like they have it
Mm.
in there real good. And
Yep.
so to think like maybe a 10-pound full range knee extension, even if the person has long legs, like a long lever, like I feel like
Yep.
you're going to need a little more force
Yes.
to graft.
Yeah. Yeah, and they're going to be limited by pain, especially patella tendon. Like, they're going to lift such a light weight generally. Like, they're going to have to be a beast of a person, like, to be able to, lift a super heavy weight that's going to come close to sort of damaging or loosening the graft in the tunnel. They're going to have to be an absolute beast to do that, and they're going to be so few and far
Yeah.
between. Where you do
Yeah, I
get a
haven't
bit
met one
worried.
yet.
No,
So
I have not, especially a patella tendon. Hamstrings, probably do worry me a
true.
little bit because there's probably a little bit more.
Yep.
It's a different anchor point, so it's just I'm a little bit more cautious with those ones. But yeah, bone patella tendons, bone patella bones. I go a little bit more
Yeah.
harder.
Agreed. Agreed.
Yeah. Do you have a preference between, like, do you have, not that I guess ultimately rehab kind of is the key, to success and navigating each graph as it comes towards you and treating the person sitting in front of you. But do you kind of also have a favorite graph you do like to work with?
I do.
Like your favorite child. You can't really say who your favorite kid
Yeah,
is, or your favorite dog, or your favorite, auntie, like, like it's,
yeah,
but we all
I
got our
have
favorites.
yeah, I
Yeah.
have to say good old patellar tendon.
Mm.
They just seem to be the most, and again, there's always, you know, an asterisk there. There's anomalies, but they seem to me to be kind of the most predictable.
Yeah.
In a way, I feel really comfortable at this stage managing like anterior knee pain that might come with it.
Yeah.
It tends to respond more like a patellar tendinopathy, which we have
Yes.
a good handle on versus, and again, um, my N of quad grafts is not as big as my
Mm.
N of patellar tendons, but what I've experienced thus far, what I've read from talking to colleagues, it does not respond it's more stubborn in terms of
Yes.
the graft site pain.
Mm.
So that was a learning curve for me.
Yeah.
Uh, and sometimes it's a little bit trickier. Not that it's, still like a good challenge and things, but that rehab process also just usually takes longer for
Yes.
people.
Yeah.
So kind of for those reasons, I think I would take patellar tendon all day.
Yeah. Yeah. Did you have a patella tendon?
I did, but
Yeah.
interestingly, I have like a knee replacement scar. Like I have a full open.
Oh, yeah. A big long one. Yeah.
My surgeon at the time was not doing like the just I mean I did still have portal holes too, but it
Yeah.
was still like a full open procedure.
Full open
So
procedure. Yeah. Wow. Yeah. Yeah. I agree. I've just started to rediscover the joys of patella tendons. I work with a surgeon up here. There's a couple of people up here, but historically in Australia, hamstrings are the preferred
yeah.
primary graft. Whereas the surgeon that refers a bit of work to me here in where I live and work now, he's primary patella tendons, and I love them. Like they're just, if you're going to insult, one part of the body, one part of the knee, just get it all over and done with in the quad.
Yeah.
Don't have a muscle inhibition as well as a
Right.
weaker hamstring. Let's just double down on the quad.
Yeah, so you
That's
had mostly hamstrings for most of your career?
Yeah, or a big chunk of my first probably 10 to 12
I feel like it's so
years.
hard to get full hamstring strength back. And at least the
Yes.
people that I've worked with, like it seemingly takes even longer than
Yeah,
the
restoring the quad strength over the long run is a bit easier, I find, to achieve. That hamstring harvest, yeah, it just there's a couple of issues where we'll probably see about 30% not regenerate. So that's a pretty reasonable number of people who just either
yeah.
the scar just doesn't develop down and the semi tendon doesn't find somewhere to sit, or it even retracts. And so that 30% of the population will always just have that probably
They're not going to regain that
20.
deficit.
Yeah,
Yeah.
yep, they'll always have that lingering 20% deficit. If for someone that's a high speed athlete, that's going to kill
Issue.
their speed. Huge issue. But yeah, that stubborn lingering hamstring difference, it's well closer to probably 18 months to 2 years until you can kind of get that back. And yeah, quads take a long time with a patella tendon, and a quads tendon. But I find once you sort of get over that first 6 months of just real irritable tendon pain,
Yep.
like you just don't have the same non-regenerations and the you don't see the retractions that what you can see in the
No,
hamstrings. And so you eventually get there, but it just takes a bit more time. But yeah, that's what I've sort of grown to love and enjoy in the last probably 3 or 4 years, which has been cool. Oh,
excited for you.
yeah, no, it's good. It's good to see the come back to the dark side. Steph, you've been great so far, and I'm just conscious of time. I know we have certainly not covered any of the questions, as many as I would have liked to have asked you. We're just,
I'm good for
like,
like 10 minutes. That's fine.
yeah. Oh no, it's been great. I certainly want to probably get a little bit more of like your hot tips and your own experiences about maybe some of your wins and losses in rehab. Both people that you've. But yeah, let's talk about some learning experiences. Always try to it's always nice to celebrate wins, but also too we learn a lot from the bad cases that we've seen. Has there been any memorable cases where you kind of think, oh, geez, I wish I would, or wish I did things differently, or I should have done something different to what I did, and blah blah blah. Yeah, if you can reflect on that.
Yeah. I mean, that could be an entire whole conversation,
Yeah.
probably. But not to scare people, but yeah, it does. It does happen. Um, I would say there's two. One was less of a I wish I had done something different and more of a I wish I had like pushed or advocated a little bit more sooner because I
Mm.
had a very weird case where very young, healthy college kid had actually like did prehab with us for like 3 or 4 months, full range, quiet knee, like great muscle tone, like going into surgery. And for whatever reason, his body like rejected like got infected and it
Oh
basically
wow.
like resorbed the graft.
Mm.
Um, but for the first like few days post-op to a week, he was fine. And then he missed a session and he said he had like a fever. And then he came in a few days later because he was like, the fever's not going away. I kind of like feel
Mm.
okay.
Mm.
But the knee was like hot. and he had lost range and he was having a lot of trouble. He was trying so hard, but
Mm,
it was one of those things. It was really early in my career, and it was one of those things that I something didn't feel right, and
mm,
I didn't push soon enough because like by another week, this was still happening. He still had, like, a low grade fever. He had gone to the doctor, but I probably should have just called the surgeon and
mm,
been like, "Hey, I don't, he's kind of regressing. He was
mm.
doing really well." So they basically he ended up having to like go in and get IV meds for the
Yeah,
infection,
the infection.
and I think they had to go in and like clean up the joint and the graft they had to take out. And he had surgery the next year, but that was one where I was like, you know, listen to your
Yeah,
instinct
yeah,
and
yeah,
speak up because I may have gotten him in early to where he, again, his parents could have taken him in. He could have, it's never
yeah,
our fault entirely, but I wished I had pushed a little
yeah,
harder sooner because maybe he wouldn't have had to go into the hospital for the infection itself.
yeah.
Maybe he could have picked up on it sooner. Who knows?
Yeah, yeah. I think yeah, for reassurance, like it would have. If the infection's in the knee, it's going to sort of sink in. There's probably a lot of those things, especially inside the knee joint. It's the
Yeah,
infection's there.
yeah.
Just a matter of time before they need to kind of get a washout. I don't think oral
Right.
antibiotics are probably going to be the thing that salvages
No,
this one.
no. So that one was definitely a little more on like
Mm,
I don't think I'll ever see that again. Like
mm, yep.
it was pretty rare. And then I would say the other case that comes to mind is somebody, this was not that long ago, actually, probably 3 years ago. Um, but one of my first handful of quad grafts, and I allowed this individual who was definitely a I always want to do more type
Mm,
person,
mm.
to kind of push through some graft site pain early. Um, and the graft site pain lasted for almost 2 years.
Yeah. Wow.
And again, like you can
Yep.
think coulda, shoulda, woulda, but I
Yep.
to think knowing now what I know about,
Yep.
like doing an even deeper
Yeah.
dive because I'm like, this isn't
Hmm.
going how it's supposed to go.
Yeah, 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 yeah.
And talking to other colleagues that now I'm pretty strict with quad grafts in particular.
Quads, yeah,
We are not pushing through graft side pain for at least 12 weeks.
yeah.
I don't want any of
They're a
it in the beginning.
beast. They're a beast, and yeah, absolutely. Like they're a tricky harvest site, and
Yeah,
that's like, and I think that's we I could we've all got those kind of things, but that's what the beauty of having a bad outcome is. You kind of can reflect on it and go, you know what, I'm going to obviously, you guys, we still make mistakes, and I'm yet to make. I haven't stopped making mistakes, and we'll always
yeah.
continue to make mistakes. But as long as we kind of reflect on it and go, you know what, I could have done that differently, and next time, and that in itself is a sign of maturity. And I think that a lot of young clinicians sort of it's easy for us, who are older and more experienced and have had a few bad ones.
Right.
It's easier for us to sort of be a bit more mature about it. But yeah, the young clinicians out there who are probably yet to make some major mistakes,
Oh,
unfortunately,
it's not fun.
no, it's not fun at all. And unfortunately, you will make mistakes. But importantly, what you learn from them and how you change and make yourself better in the future is a big one. Like
Yeah,
I don't know, my first probably 2 or 3 years, I had a number of re-injuries,
yeah,
second, graft failures that were kind of on me. I sort of reflect and go, well, we kind of were only operating on time-based criteria back then, but even still then, I've had a couple of patients who have re-injured after, passing criteria, or
yeah,
I've kind of been a bit loose with my sort of programming and not, I had a circus performer, not circus performer, cheer performer, who was kind of under my management, who was really pushy, physio student, really pushy, wanted to sort of really get to a competition. And I kind of was opening up a little bit more, giving her a
yep,
lot more rope than what I would normally give. She
yep,
was, I think maybe less than 12 weeks post-op before she ruptured her graft again, because she was doing doing some, for like, basket catches, like, so
Yep.
she was already up high. And my reasoning was like, well, she can balance on one leg on the gym floor, her being held up here by some
Yeah.
strong guy, that's probably no different to what she's doing on the floor. But inevitably it was like, once you give them that little bit of rope, it's like, well, he's saying I can do this. Maybe I'm just going to test the waters and do something. So, she was then, without my permission, so to speak, she was doing cartwheels and flips and just
Mm.
taking that inch and running a mile with it. And I'm
Yep.
like, damn it, I should have just pulled on the ropes a little bit harder with her,
Yeah.
because her surgeon was pissed. Oh my gosh, he was pissed. So, and I was
Yeah.
like, well, so that was my big learning experience. Is like, yes, it didn't happen in kind of an incident where I expected it to happen. She kind of went a little bit further than what I'd allowed her. But I think for some people, you got to put those safety guardrails up a little bit,
Yeah.
even with, there's some
Yep.
people I
Yeah,
do
you start
worry
to learn
about.
those personalities a little bit more, maybe the people you need to kind of keep the leash a little bit shorter.
Oh, yeah.
But
Yeah, so
it's hard because you want to
some
please
need to
people too.
push. Yeah,
Yeah.
exactly right. That's the niceness in us, that inherent nice person. But also too, we have to be, nice but firm, and a bit of tough love. But yeah, for some people we need to actually, push and go, say, yes, it's fine to do this. You know what? Like, you've got an ACL injury. It's okay to shoot free throws at six
Yeah.
weeks if you're weight
Yep.
bearing. Like, you're not playing one-on-one with someone, you're not playing full court press, you're not doing anything
Right.
super risky. But to put a basketball in their hands and allow them to dribble and feel like an athlete again, the smiles on people's faces, that, when
Right.
you give them that little bit of a win, that's very empowering for them. But then you also too
Yep.
need to understand, is this person going to then now start playing one-on-one with their brother, or is it
Yep.
or is it going to be they're just going to take that huge win as it is? So
Yep.
that's what I love about ACLs. We said that at the start. Each ACL that you meet, it's a 3 centimeter part of tissue, but it's the person and their brain and their motivations and personalities is a really interesting part of the rehab journey for people. So
Yep.
cool. All right, last question before we wrap up. What's one
Yep.
piece of advice you would give a young version of Stephanie Allen, as a young
Mm.
PT new grad? What would you, as an older physio now with a lot more experience, what would advice you give to your former self and a whole bunch of new grads that are watching and listening to this?
And do you mean like specific to working with ACL or just in general?
Both ACL and then just life,
Yeah.
physio life.
Yep. I think ACL specific, that I would say keep asking questions, because there are times where I think that you read a cool new paper and you're like, I'm going to do this with everyone. And
Mm,
it's like, that's great. Like, you want
mm,
to try to kind of implement what you're learning. Um, but I think, to your point, being able to take incoming new information and kind of see how it fits in with, what you already know in terms of
mm.
kind of core principles, and with different people, how it works in a clinic setting versus yours if it's different. Um, and on the flip side of that, continue to kind of ask questions and self-audit yourself. I think that's
Yeah,
the and that probably applies to both ACL and general, because I think that one of the things that, when I started to talk to kind of colleagues and formal and informal mentors a little bit more, after all those conversations, I always kind of would go back to, you know, the way I'm doing things, programming, general ACL principles, my beliefs in general about, we all have biases and beliefs. So, um, I would always find myself going back to those and thinking like, hmm, like I always thought this, but I'm not so sure about
yeah,
that. And I think those little times of kind of like repeated self-audit, um, got me to a place where I feel, again now, where big picture, I feel really comfortable. Like, I have a good, confident handle. I feel like I can guide most anyone with kind of pretty much most knee injuries.
yeah,
Um, but I always kind of feel like there's still more to learn. And I'm kind
yeah,
of looking back at any like templates I've made, and like looking and seeing like, would I change that? I think that having that little kind of question
Yeah.
has been super beneficial to me without it being like always assuming that you're wrong and not having confidence. So I think that's
Mhm. Yeah, yeah, yeah,
the
yeah,
balance. You could easily be like, oh, well, there's, especially from a programming side and like
yeah.
virtual programming, like you could go down rabbit holes.
Yes.
But oftentimes, simpler is probably better.
Yeah, absolutely. That's a really good message. I think that, yeah, I just, yeah, do and reflect, constant sort of do and reflect, and,
Yeah, it's
I think
hard
that's,
early on. Like you just want to keep
yes,
learning and doing. I didn't reflect much.
no, no.
And so
Yeah. And
I
it takes time. It takes time, and you need, early on, you need good mentors to also to help educate you, but you also need to be, actually getting some skin in the game, and doing things and not being afraid to make mistakes. I think that's where a lot of clinicians are probably getting worried about failure. And it
yeah,
sucks, making mistakes. They're not easy, but it's just a part of, I guess, what we need to go through as clinicians to help our patients get better. And yeah, there'll be a few bumpy ones along the road.
yeah.
Steph, you've been wonderful to chat to, and thanks so much for sharing your experiences, both personal and clinical. It's been really enlightening. So I appreciate greatly. Feel free to, where can people find you? If they're watching and listening to this, if they want help with their ACL rehab, give yourself a shout out of where people can find you.
Yeah, of course. Yeah, this was so fun. I feel like I could, easily
Oh,
talk for another hour. It wasn't my
there's hours to
bedtime.
go. Yeah, you got to go to bed. I got to go and, I don't know, go and make another cup of coffee or something.
Yes, yes, yes. Yeah, so most often on Instagram, I'm just stephallen.dpt. We have a website too. It's just aclresolve.com. Those are probably the areas you'll find me most. Like I said, I'm also a mentor and co-founder of Clinical Athlete. They're just Clinical Athlete on
Yep.
Instagram too.
Awesome.
Kind of two worlds there, but yeah, open book. So any questions, you know where to
Perfect.
find me.
Awesome. All right. Thanks, Steph. Well, thanks everyone for watching and listening to this one. As always, I appreciate the support, and yeah, stay tuned for the next episode on the ACL Hub. See you next time.